Hello, dear colleagues. Hello, my name is Mynzhylky Berdikhojayev, and together with my assistant Abzal Jumabekov and our friend and colleague from Tajikistan, Kamil John Abdusamadov. Today we are in National Hospital of the Medical Center of the Presidential Affairs Administration of the Republic of Kazakhstan. Almaty City in Kazakhstan, it's a presidential national hospital. And also I want to congratulate my colleagues and my friends from Kazakhstan. Today is the Independence Day of Kazakhstan. Since 1991, huh? 91'dan бастап қой или 90'dan бастап қой 91'dan бастап кішкентай аневризмасы бар екен да. Case number 1, patient is 79 жылғы да, 46 years old female, previously had a headache and seizures in August this year. And in September we did a embolization for the brain AVM in Kızılarda city, which is my native city. Near the Aral Sea and Baikonur space station. It was the first session. We tried to occlude as much as possible the brain AVM. And now session number 2. The first session was on monoplane car, on monoplane machine. That's why without 3D angiography, without any other possible options. And now we can see clearly patient is partially embolized, and there is a Hübner artery which is coming from the ACOM region and feeding the AVM. The only point, also there is a lenticular-striating artery might be. It's a complex location. Abzal made a 3D angiography, and let's see the 3D. I'm not sure it will be clear, but this is a lenticular striator. Maybe it comes, maybe not. Okay, first of all we will go to the Hübner. I think this anatomy is friendly. Option number 1 come from the ipsilateral side. Option number 2 come from the contralateral side. We will take Sonic 1.535. Sonic, I think the one Sonic might be enough. I'm not sure about the headway duo. If it will come till this point, maybe okay. If it's not. At this point might be a little bit challenging. It's possible to balloon assist from here. It's a possible option because tortuosity and the navigation of the microcatheter could be a little bit challenging. Also, there is ACOM, and maybe it's possible to come from the right side. And then after occlusion of the territory from Hübner, we need to check this point. This artery is accessible. If it's needed, we can use balloon assistance. And it looks like from the MCA, distal part is already occluded. Let's see the AP and lateral. It's look like this part is clear. The most part is from here and might be from the straightening artery. Okay, maybe we'll place a balloon. I think it should be a good option. Also, it's possible to come from the right side and to navigate straight forward from the ACOM territory. If it would be unstable, then we may come from the ACOM territory. Okay, let's see, let's start. Abzal is opening the instrument and I will join in a couple of minutes. Okay, Kamiljon is asking about the possibility of venous access, but in my point of view, the venous access is a little bit complicated. It's directly shunting to the cortical veins and from sphenoparietal sense, and in distal part it's very tortuous. And usually this region should drain into this deep venous system. Обычно глубокий дренаж он должен отдавать, но здесь мы его не видим. Okay, usually it should go to the straight sinus and the deep venous system, but here we have no those drainages. Yes, this is very tortuous. It's inaccessible. Очень извитой. I think I would not try. There is a stenosis, and on the first embo we have seen the edema around the AVM. It was ruptured edema and slight small size hematoma. The possible option in this case to go with a hybrid surgery, open this point, puncture, or just open this vein in sphenoparietal region, and then go venously. It's option number 2. Huh? It might be, but I'm not sure. Should we do it like this or not? Okay, now I will ask to open Eclipse двухпросветный ашпеш. Eclipse 2. И не наш пересол. Чекай. Джо. Чекай блок ашпеш. Ага, чекай блок. Yes, we will open the Chikai Black. Екі набор шприц ашасыздар ғой. Екі ДМС жинап қойсаңдар. И экранды бір 10 сантиметр менен тартасаш. Так, там трехходовый берем. И Y коннектор керек. Okay, we prepare the Sonic 1.5 by 35. Unfortunately, the company in December has only this size. That's why we should work with this. It's not a private practice when you may have all instruments, but it's okay. I think it's okay. I hope it's okay. So I asked to open the Eclipse double lumen. We'll use Eclipse for the assistance, for the balloon assistance. Yes, and also we can check the lenticular straightening artery territory with the Eclipse. Пятерка шпиц пересол. Шпиц пятерка пересол. Yes, we will place first of all. Yeah, отлично. Спасибо. Рахмет. Yes, the operating nurse is Zoya, and we have anesthesiology team. Anesthesiology not here. Okay, anesthesiology team. Yes, now we will prepare the Eclipse double lumen. I took 3 cc contrast and 2 cc saline, and then it will be 60%. Huh? From my knowledge from chemistry and mathematics, usually it's a 60%. I hope I'm not wrong, huh? Okay. Probably I'm right. Huh? Okay, we need to ask ChatGPT. I'm joking. Yes, it's 60%. Now, I think balloon already sealed, and the air bubble is not going out. That's why I will place the tip of the balloon inside the saline, and I will start to suck, and at this point the air bubble is coming first, and then in the microcatheter remaining the contrast part. It's very important. If I will continue to push, the balloon might rupture. It's a small tips and tricks. I think in the instruction for the balloon it was described, but nobody is reading the instruction. Usually it's practice. Okay, after the operation I will try to check the instruction. Yes, now we can see there is an air bubble which was inside the balloon, and then balloon is ready. We place 8 French short sheaths, which is prelude from Merit Medical, and through the short sheaths we placed Asahi Hyperion, which is coronary guiding catheter, 8 French. 2 Y connectors, Eclipse double lumen, and this is unical wire from Asahi company. And also we have a Sonic 1.535 with the hybrid inside. It's a regular one. It's coming with the wire. There is also the boxes without wire inside. SG. I don't know the explanation of SG. Назад. Okay, I think this is for the Sonic is better. We especially took 8 French system. If it's necessary, we can also place inside one more microcatheter if it would be necessary. Чуть-чуть назад. And also today at 3 p.m. Astana time, 3:30 Indian time, we are planning with Rajiv Sivasankar the video podcast concerning the giant aneurysms. Rajiv asked me to do presentation on giant aneurysms. Okay, maybe I will do it like this. Okay. Then it should prevent me from human factor and mistakes. Huh? Okay. Okay, we have for several months the problem with the small focus on the AP, and we already informed our administration, and the problem still remaining. That's why it might be small nuances with the visualization. I think it's cool. This looks like MC territory. We will place the balloon in the MCA just at the beginning of the MCA to be able to do console angiography. I think this might be the Hübner. Okay, now we can zoom it. This. Okay, let's see the 3D roadmap, how the Hübner is a second. can see the Hübner a little bit clearer now. Might be. I think it's not inside the Hübner. It's inside something else. It's a frontopolar artery, I think. Smart mask. Yes, it's AC territory. Might be a little bit problematic to go to the Hübner. I think Hübner is coming a little bit earlier. Okay, let's see. First of all, we need to change the curve of the microcatheter. Yes, it comes a little bit earlier. Yes, it comes a little bit earlier. And then it looks like a little bit spasm inside the Hübner. It might start thrombose, Now we can see clearly there is a supply from the lenticulostrating artery. Then it's clear, Okay, last brayer. Just a second. Okay, let's place the balloon here. Now we'll inflate the balloon and он меня просто бросал, пока не титр. Listen, bro. Just a second. Окей. Зажим берег. Все шахта. Yes, Abzal had a porridge in the morning. Yes, that's why he has power, and he connected the Y connector to the balloon very hardly. So it's very important to have the team already had the porridge. This part is clear. There is pile collaterals, I think. That's why we can see the territory nicely. Now we can deflate the balloon, and we will place the balloon at the proximal part to see clearly the territory of straighten out to clarify the anatomy. Yes, there is a supply to the AVM. We need to change the position. Also, let's check the Hübner territory. I don't know why, but now the Hübner territory is blocked. Might be because of multiple devices inside. Might be. Okay, we'll place the balloon a little bit forward. Okay, I need to close the balloon to prevent any mistake. And this syringe is kaput. Kubowy szpic, jak chcesz? Yeah, there is a unique vein, and it's possible to occlude the AVM from one of the branches. It looks like it's supplying, but it's thrombosed. I don't know why. Maybe spasm inside, maybe. I hope there is no bleeding. I don't know why it's like this. Okay, also smart mask. Okay, let's check what we can do in this situation. Так, no, really? No. Yes, maybe the navigation from the right side could be more suitable, huh? Maybe the navigation from the right side could be suitable. Huh? We'll see. We will see. Maybe we will ask for the second guiding catheter, which is 6-inch guiding catheter. It's very surprising why this territory is stuck so quick. Okay. It's quite challenging to go with the U-turn, huh? Yes, the anatomy is challenging, that's why there is a big turn, and the 1.5 sonic is a little bit stiffer. Huh? Goes down. There is a one turn and then second turn. Okay, just need to reshape it. Jestem kiesel. I volksom kiesel. There is something, and also the AVM is feeding from this point, huh? Okay. Нимата по-споя се знаеш? Ясно. Yes, maybe we need a cocktail from Naimodipine and saline. And it might be very helpful. This I learned from Rene to do very little J shape with just a fingertip. 15 milliliter. Okay, 15 cc of nimodipine, which will be 3 milligram. Okay, smart mask. A little bit release the non-catheter. Okay, let's check the position when it was more straight on. Okay. Something like this, huh? Okay. It's like this, huh? It's going like this and like this. 22, 26. Назад. Вперед. Назад. Артериальная фаза. После. Стоп. Назад. Вперед. тағы бір Sonic 1.5 ашты десеңші.
Sonic 1.5.
Now we are on this projection. It looks like we are here. So we'll see. Oh, you know? Just a second. Yes, it should go up. Up, up, up. The marker of the Sonic is stuck. It's stuck in the connecting point. Huh? Okay, now it's going up. Then there is a turn, one more turn. Okay, let's check the geography. It looks like it's possible to push a little bit more, a couple of centimeters. It looks like it's thrombosed, huh?
Yes.
It looks like it's thrombosed. Let's take in another one. I think before the injection of anything, we need to go and check this city control. I think it's very necessary. Yes, there is branch should go up, but it's not coming. There is other branches. I think going with something like headway duo might be challenging, huh? Okay. At this point, the artery should go from this side and up. Huh? This artery should go like this. Yes, now it should go like this and this. Okay, I will ask Abzal to prepare the DMSO for any kind of emergency.
Okay.
Okay?
It's all already prepared.
is prepared, and also I need a squid 12 on the table.
Okey.
Aldırasın.
Tabii.
Squid tonik. Alır.
Şuna vereyim.
Ya, squid tonik'ini alır. Okay. The last part of the manipulation is all the time a little bit risky, and there is a balance between to have a long reflux and the occlusion of the normal territory, or to take 10-15% of risk and to go distally. That's why we should prepare the liquid embolic and put it on the table. Предыдущий родной тхайсл. Полностью проверь. Smart mask. Okay, we have a referent image, which is very helpful, and then we have an image from the beginning, from the global view, and now we have a wire which is go distally. One more curve, and then the liquid embolic injection might be more safer. This we will use for the assistance. The sonic is all the time try to go for the MC, M1. That's all. This extra 5mm might be very helpful. As 1.5 and 1.2mm in this kind of situation is very crucial. Huh? It's very important. Okay. It doesn't want to go, that's why let's start from here. Also the option number 2 to place the second microcatheter and to do some injection. Okay, let's occlude the balloon. I hope we didn't do any harm to the patient. Now we can see clearly the lenticular striating territory. Yes, it looks like something happens in MCA territory. Назад. Maybe spasm in ACA, maybe spasm. There is no AVM, no? Okay. But AVM is there, but okay. AVM is there. Okay, I will ask Abzal to do city. Okay, let's do city. I will shake it. Тоже? Кітті тұрып бір қарап алайық, өйткені спазм болды, не понятно. Okay, city is ready. Let's check. There is the instruments. There is a previously treated part of the AVM. This is the balloon, I think, with more densely part of. This is draining vein. Yes, we have also the option number 2. It's a microsurgical resection. Yes, the remaining part could be resected. There is also gliotic transformation around the AVM. A little bit later I will send to the WhatsApp group the images, MR images. Okay, let's see this. Okay. Okay. I think we can start from this point. First of all, I will check the proximal ICA. And also the brain part. Huh? Okay, let's check part of the brain. Yes, the slight spasm. Okay. MCA territory is clear, and the most of the part of the AVM now is supplying from the lenticular-straightening artery. Okay. Наркоз поглубже, дексаметазон. Уник миллиграмм. Yes, now we ask for the deeper general anesthesia and the dexamethasone. Okay. Let's see what we can do. Назад. Чуть-чуть назад. Назад, назад, назад. Стоп, вперед. I think till the second curve we can do what's this? Все хорошо. Уник миллиграмм. Уник миллиграмм. 12. 12. Ага. Squid уник, да? It's a squid 12. Yes, it will be very quick reflux. That's why I will ask Abzal to keep the eyes on the system. Yes. Now there is a reflux till the second turn, as we planned. I think more proximal reflux is not necessary. Повторно ровно. Сквитның қалдығын алып бересіңші. I will put the timer. We would not touch the sonic till the minute number 25. It's very important. The traction on the system should be very, very slow and slightly. Yes, there is a reflex. Okay, I will ask Abzal to give me the shake part of the squid. Анан қайтадан құйды, айналдырып жүрсің. Айналдырып жүрсің. Ішіне құйды, қайтадан айналдырып жүрсің. Yes, I took the more fresh liquid embolic. We will do the push and plug technique. It's a classical technique, and it will take some patience and yes, we have time, and we'll do step by step, slowly. Yes, it will go forward. It will go to the AVM. I don't want to touch the striator territory. The navigation is also challenging and lenticle straighting also. Возможно. Okay. Let's take the lenticle straightening artery. It's coming like this, and then there's a turn number. There is a bifurcation here, and then it's turn, and then another turn, and then it goes to the AVM. Yeah? So many turns, and also we need to work in the lenticular straightening territory with the Sonic 1.5. Okay, the reflux is coming. We don't need more. I think it's enough. Вперед. Вперед. Yes, the AVM is still there. I'll bring the balloon a little bit proximal to do less confusion. Yes, for the case of any emergency, we can push the balloon in MC territory. Okay, now the sonic is more clearly seen, and you can check the reflux on the lateral position also. Назад. Stop. Okay, smart mask. Road map. Yes, to explain for the younger generation, the AVM in basal ganglia location, it's quite difficult type of the brain AVM, and it's not the AVM to begin with the embolization. Cortical distal location, single feeder AVM is learning and teaching AVM. If you have a distal part of the pericaudal artery on the right side in parietal lobe, 1 centimeter AVM is a learning AVM, student type of AVM. Even the occipital lobe is very eloquent area, and patients might have a quadri anopsia or hemianopsia. It's also disturbing the patient, but the right parietal lobe medial part, it might be some acalculia. Okay. Or dural fistula. Dural fistula is also the learning AVMs. The learning pathology. Okay. Okay. I will ask Abzal to check the lateral view for the reflux. I will focus mostly on AP, anterior posterior projection. There is a reflux coming, but it's not so much. I think it's better to stop now. Then the liquid embolic start to go distally. It's still in the feeder. It's still in the feeder. Yes, it's in the feeder. It's still in the feeder. We can see it like this. This is a feeder. It will go up and then go inside the area. It's like this. Yes, it needs some patience and patience from the doctor point. To deal with such kind of pathology, you need to be very patient. I'm focused on AP reflux. Abzal is focused on lateral reflux, and Camille John is focused on flushing system. It's very important. To keep your eyes on the flushing system is very important. Now we are starting to penetrate the distal territory of the feeder, and also there is a small part, small afferent coming from the middle part of the artery, Hübner. And now we will start to penetrate, and I will ask Abzal to give me the previous syringe of squid.
Yes.
And at this point we need to keep in mind we have also the lenticular striator feeder, and we have exclusive one draining vein, and which is also very important. I think now we are in the draining vein. I will ask Abzal to check the super selective runs to check the draining vein. It's very important from this point to see the drainage. Okay. I think now we are completely in the draining vein. And also it's looked like we started to penetrate the lenticular striating territory also. Yes, we started to feel a little bit the striator territory. Венасын қарасаш, ең басындағы суперселективный болды ғой, ең басындағы. Ниже, чуть-чуть, вот это. Жоқ, ол емес. Выше. Жоғары қарай. Ага, жоғары. Еще жоғары. Осыны қойшы. Не суперселективный, а обычный. Венаны қарасаш. Төмен түседі, да? Okay. It's going laterally and down. Okay. We have a distance. Now we see the direction of the vein. I will ask Abzal to keep this image. It's very important to see exactly the orientation of the vein, orientation and the direction of the draining vein. It's very important. Okay. At this point, usually you want to push a little bit hardly, but then 100% probability of reflux. That's why slowly. No rush. Slowly. At one point the feeder might rupture. I think it's this situation. Now I think we ruptured the feeder. Maybe not. Let's see. Oh no, it's a feeder. It's another feeder. It's going inside the AVM. And at this point might be the reflux. I will ask Abzal to keep the eyes on reflux because we need the 4 eyes instead of 2. It looks like AVM. I think it's a draining vein, or it's a feeder from the lenticular striatum. Okay, let's check. It might be draining then. Stop. Yes, it looks like draining vein. Yes, it's need some time and patience of the doctor to prevent any kind of reflux. At this point you want to push and to push hardly. It's a draining vein. I think it's a draining vein. It looks like the vein. It's a little bit bigger than Yes, it looks like it's going down. It might be the second vein, it might be the second vein. It's also very important to keep in mind we might cause the rupture of the AVM at any point. That's why should be very cautious. Huh? Yes, at the end we will check the lenticular straightening artery. It's very important. If the liquid embolic will come till this point, it would be marvelous, huh? If it will come till this point with the reflex. Yes, no rush, we have time, we may control the feeders, that's why. We just need to pray for the patient to have a successful treatment. It's very important, huh? It's very, very important. Because we are dealing with the human, huh? It's very important. Yes, it looks like it's coming. Also the very upper part of the AVM is not penetrating. The small part is penetrating. Now it starts to go. Start to go to the distal part. It's very good. Reflex қарап отыр. Жаңағы стриадный артерияны көрген жерді қоясыңшы. Now we need to check the point of lenticular straightening artery. It's very important. Yes, straightening artery is still there. Осы снимки қоя сал, стриадный артерия. Стоп. Назад. Осы жерде. Okay, like this. Ана жағынан қоя сал. Yes, and you should notice that we are working only with the squid 12 without any pressure cooking, and many colleagues are scaring to use the squid 12 because of the possibilities of reflux formation. I think we are going to the draining vein. Huh? Okay. It's also important to occlude the beginning part of the draining vein, and then we retrogradely may occlude the AVM. Yes, it's very important. Okay, let's see the venous part. It's a little bit unclear where the AVM is draining from the lenticular straightening. It might be like this. I'm not sure. Yes, at this point the 6D possibilities it's without any competition. Huh? If you have 6D and you can see the straightening artery coming point, it's very important. Okay, maybe one day The Philips will also start the 6 or 9 or 12D. Okay, let's see. Чуть-чуть даемся görüşür. Okay, the reflex is coming. Let's wait for 1 minute, and then we can inject a little bit dimethyl sulfoxide, because the reflex is coming back. It's the sign that the pressure in distal part is very high. Non көтерме. Yes, the vein is very slow. The blood pressure is 95 by nearly 60. Arterial fazını koyuyorsun. Arteria. Stop. Okay. It's a technique we learned from Shimon Maimon. After the injection of the liquid embolic, if you have no the penetration to the AVM, then you can take dimethyl sulfoxide, which were published in 2009 or 2012 by Shimon Maimon and the team from Israel, from Ichilov hospital. It's possible to inject the dimethyl sulfoxide, and you can dilute and push the liquid embolic forward. And also this technique is helping to retrieve the microcatheter without any hard attempt. In 2012 I have seen how the René is modified this technique from Shimon Maimon, and after a couple of cc liquid embolic injections, he just injected 1 cc of dimethyl sulfoxide. It was the modification from René Chapeau. Okay. Let's wait a little bit. And then the next portion of the liquid embolic after 1 cc of DMSO is going very easily. I'm not propagating to inject the 1 cc of DMSO, but usually 0.2 or 0.45 cc of DMSO is enough. Okay, we'll put it here. We will just flash the balloon. Okay. Yes, it's nice technique, and we are using it. But with new liquid embolic like Aptura from IHT company, Spain, I think it will be not necessary, because Aptura has no tantalum, and it's a little bit different material, different technology used. It's based on iodine, and if you leave the microcatheter for half an hour with the squid onyx, usually 2 minutes is too much. But with Aptura you can leave the microcatheter for 45 minutes. We left the microcatheter, and after that it's possible to inject the Aptura and send it forward. Now we can see the reflux, it's reached the first marker. Okay, let's change this syringe. We'll wait for another 2 minutes. Now it's possible to wait 2 minutes because we injected the MSO. Yes, with Aptura we just left the microcatheter, and after 45 minutes we started, we continued the injection of Aptura, and it was looked like we waited for 1 minute without any problem. Aptura is penetrating through, and it's a little bit different technology. And the tantalum is staying like a roof. Черепица делала что-то. Yes, like this. One by one. Okay. It's precipitating. As we start to occlude the vein, that's why after this microcatheter we should go with another microcatheter to the lenticular-striating artery territory to check the AVM. No, draining vein is there. Lenticular-striating is still functional. But this point is a little bit dangerous because the AVM is still functional. And vein might thrombose because we decrease the flow inside the AVM. As the draining vein might thrombose, and it might cause the AVM thrombosis usually with rupture. That's why after the case we will do CT on the table, and the control CT. Usually we ask the anesthesiology team to bring patient for the CT in 1 or 3 hours. It's a follow-up CT on the first day of embolization. It helps to exclude the possible early complications. The next CT will be in 24 hours, and if it's needed, we can do MR control in next 3-4 days, if it's needed. Okay, let's wait for a couple of minutes. The only problem, we could place one more Y connector at the beginning. Then it might possible to use the third microcatheter. Now if we will place the third one, the saline will start leak back. But it's also not bad. Не деген наш персонаж, гибрид емес, чекай с 008 сол жерде жасыл коробкада тұр. Okay, but we can place the second microcatheter with no problem. I hope it will be no problematic. We asked for Shikai 008, Shikai 8, which is small version of Shikai. René Chapeau prefer the Shikai X, which is Shikai 10. but in Almaty now we have mostly Chikai 8, which is also not so bad. But usually the smallest size is less stable. Свежий дым существенно происходит. Зиомблю, он коронарный, он имеет больше поддержки. Чикай, он более мягкий, он интракрaniальный. То есть вот эта часть 30 сантиметров мягкая. Camille John is asking what's the difference between Chikai and Zion. Zion, which is coronary guide wire. The most difference, Zion blue, the distal only 3 centimeters, дистальные 3 сантиметра мягкие. The flexible part on coronary wires is distal 3 centimeters. With the narrow guide wires, usually distal 10 to 40 centimeters flexible. Reflux is coming, huh? It's not like there is a reflux. Oh no, it's going forward. Вперед идет. И вперед и назад, да? Вроде бы. Артка от живота. Чаще артка живота, но в основном алдыга живота, да? I think it's a rupture. Жыртылған сияқты ғой, да? Ана жерде андай тамыр болған жоқ па? Let's check the 3D. It looks like extravasation. Let's check the AP. At this point, it looks like something extravasation, but it might be also the vein, huh? Or it's it might be the vein. Okay. Let's see the lateral. And lateral is here. Okay, let's continue. Maybe it's not the extravasation. There is another branch. It was looks like the venous branch, but let's see. I think it's extravasation. Похоже, экстравазация. Ладно, пусть тут так полежит. We can leave the first sonic and then in parallel this and this. Just a second. Okay, I hope we did not damage the sonic. Okay, it starts leaking. That's a usual thing. Let's Okay. Aşırı sar. Then we need to push the balloon forward. Okay, just a second. On est. Гибрид, ходи, обалишь.
Почта.
This will take a check back. Smart mask'ın roadmap koysa şimdi.
Navigate bana.
Navigate, ha? Navigate. Ана ненің давлениесі түсіп кетеді қазір. Қарып қойсын. It looks like it's a little bit damaged, huh? Okay. Yes, the problem is the Sonic is oriented okay, now it's going. Let's take out the first Sonic. Okay. No problem. Looks like there is some problem with the solid. Huh? It's look like we detached the. Oh no, it's okay. It's detached at the mark. Okay, just a second. We need to little bit pull the balloon. Now I think it's more assistable. Something like this. Okay, let's check the engine. It's not uneasy, huh? Not uneasy. It looks like it's thrombosed, huh? I think the same situation with the previous branch from the Hübner. It looks like there is a thrombosis, huh? Stop. Okay, let's do angio from here. Oh, the veins start thrombosing. That's why the flow inside the AVM is still. We need to go distally and need to just occlude this branch, huh? We should occlude this branch. Назад. Stop. Назад. Вперед. Yes, it's going up and going down. It's a feeder from the AVM and okay, let's see the hybrid. Maybe hybrid will work. Дем со свержена ходьба. Okay, we will need the unik jineso. Свежий. Так, на смарт mask vessel. Yes, for this case, it's better to work with something like Hyperglide Scepter for the assistance, and it might be better to work with the 1.2 device, which is Magic or Sonic. Unfortunately for the Magic we have no glue. We can do off-label thing like a liquid embolic injection very fast, but it might be risk of microcatheter damage. That's why I will prefer to try to continue with the here. And there is a problem, huh? The problem with gravity, your assistant is a little bit hardly can listen your voice. It's one possible point from zero gravity system. I think the wire is already damaged. That's why it behaves like this. Huh? Okay, let's take Chikai version. It's impossible to work with this device. It's already damaged, I think. But for the distal navigation, it's better to have something like hybrid or Traxxas 7, which is not available now in the operating room. Okay. Quite stressful situation. Huh? Okay, maybe we will ask for one more Shikai 8, one more. Bruno, что слышишь? As the balloon is quite distal, that's why the navigation is complicated. It should be better. the orientation of the microcatheter to the down part is a little bit also complicating the situation. Okay, let's deflate. Let's check. Yes, the vein is now completely stagnating. The AVM thrombose and occlude, but it's better to check. Yeah? Stop, smart mask. Okay, let's change this device. Upstairs. Upstairs. Yes, when you deal with the AVM, it's not all the time easy. Huh? And never say easy. Then you will have all possible complicated situations. Huh? That's why it's quite challenging disease. Huh? Challenge, yeah? Challenge. Айналайын деген ғой да. Is this 360-degree angulation? Downstairs it's easy. We need to go upstairs. Sonic былай қарап тұр да. Sonic is oriented to the downstairs, but I don't want to rotate the microcatheter.
Tartış.
Правильненький зал.
Писаешь.
I did a more J-curve. Чё, Камильджан? Сложно, да?
Я смотрю, вроде получилось, а не знаю, дальше по-моему, все получилось.
Чуть-чуть сохраняется кровоток. Да. Это стоит бессонной ночи моей. The price for finishing at this point is my night sleep today. Yeah? Not only my night sleep, but also the whole team. That's why, if it's possible, we need to be sure that AVM is completely gone. Yes, it looks like vein start thrombose. It might be very helpful, but it's better to be sure that everything is completed. And at this point, I'm a little bit disappointed with the behavior of microcatheter. Microcatheter is going down and it's a little bit stiff. That's why it's additional point. And also the wire is behaving not as I liked. But from this point is a little bit problem to push the microcatheter. You see it, it's going between microcatheter and between balloon and the artery. I just need to go to the orifice of MC, but the problem is Sonic is oriented to the downstairs. Huh? Алжишься? Қатырақ жүр. Басқасын жалғайсашы. Басқа система жалғайсашы, свежий. Басқасын жалғайсашы, пока тромб түзілмей тұрған кезде. Patient is look like moving, а? Пациент, кажется, шевелится. There is a bifurcation. Система экстракт пересылдыр. Okay, just a second. I will deflate the balloon to give the perfusion for the brain. And now patients start moving. Мына неден көрсетші, қалай болған?
Зояны тоқтады, ашты.
Мынаны алсам. Делаю.
Все, устроилось. Пункт уже.
It look like AVM thrombosed. Oh, it look like the AVM thrombosed. Yes, it all goes to the. Okay. But anyway, we should check the territory. It's better to check the territory before saying we have done everything, huh? There is another vein. It looks like without any block. It goes medially. I think this part is going without any problem. Then it might be resected or sent to gamma knife. Huh? But the gamma knife colleagues usually don't want to deal with the previously occluded AVMs. Huh? Okay, no idea. Yes, nobody want to complete the. Usually, nobody want to complete the work of the other colleagues. That's why it might be like this. Everybody wants to deal with the fresh patient without any surgery before. Then it's no need to work with gamma knife, huh? If you want to work with fresh patients. Алдында бір жасағанда AVM көрініп тұрған слайд қойсыр. И мына жерде роднот қойып бересіз. Осыдан назад, смарт маска. Назад. Стоп. Осылай. И алдындағысын мына жерде қойып берші. Басында көрінген, ана микрокатетермен бір жасаған кезде көрінді ғой. Кажется, Ана пациент оянам деген кезде шығып кеттік қой. It's a double number 2. Huh? Yes, we just changed the tip of the wire and everything is moved, patient is moved, anesthesia is finished. Okay. If it will be easier, then everybody wants to deal with this pathology. Yeah? That's why nobody wants to deal with this pathology, because it's quite challenging. Yeah? I think it's time to stop. Huh? There is a draining vein and there is no problem. I think it's time to stop. Okay. Oh, okay, just a sec. Yes, there is not the same draining vein anymore. Now we will do angiography. Now we have two options. Option number 1, do nothing, and option number 2, call the Marat Sarshayev and ask to resect the remaining part. Call the Superman to go to the craniotomy. Okay, it's not like everything is occluded. There is a spasm in one segment. In this part, there is a spasm. Let's do angioplasty, and then we can go out and finish. Двадцатка шприц пересажу. Okay, it's very important to do hijama. Hijama is a blood evacuation, but it's an endovascular one, not the traditional hijama. Yes, the draining vein is thrombosed, that's why I hope everything is okay and the AVM will not bleed. Huh? Okay, let's do control angio. We'll keep the patient under general anesthesia for another 6 hours, and in 2 hours we will do another expert CT. Let's do expert CT. Great job, Cecil. I hope so. It's AVM and it's all the time a surprise. Let's see the angio before and last angio. Just a second. It was like this. The artery was like this. We need to keep in mind. And then let's see the last run. It's look like the same. It's very important to check the same projections. And there is a small clot in distal MC territory, but there is a rich collaterals and it should be okay. With this part everything is clear. And let's see. Let's see the expert CT. It was a draining vein, and I hope this part of AVM is okay. Başarı. Böyle başarırsan, işine kırıp başarırsan. Okay, dear colleagues, now we have a control CT. The ventricles are clear, which is very important sign because the AVM is very close to the anterior horn of the lateral ventricle. And now you can see this is a thrombosed draining vein, and brain is clear. Let's see the recipient lateral. This, I think, is a calcified falx. And the brain is clear. This part is thrombosed vein with the contrast stagnation. We'll do control CT in 2 hours, and we ask the anesthesiology team to keep the general anesthesia for another 6 hours, and then we can check what is the possible risks, and I hope it will be okay. Thank you for watching. See you in next 30 minutes. Next case is brain aneurysm.